Hey, hello, everybody. Thank you for joining us on Zoom and in person for our presentation by Dr. Ghazal H. Kango on a guide to cancer screening in 2025. Dr. Kango is a medical oncologist and hematologist. She obtained her medical degree from the George Washington University School of Medicine and completed her internship and residency at George Washington University Hospital. She further specialized in hematology oncology through a fellowship at the University of Maryland Medical Center. Please note that the speaker is unable to give medical advice. This event is simultaneously being shown on Zoom and is being recorded to be publicly posted on the library's YouTube channel. Thank you. And now we welcome Dr. Kango.
Hi, everyone. Thanks for joining us today to talk about cancer screening in 2025, which I think is kind of interesting to have a medical oncologist talk about this, because usually cancer screening is actually something you talk about with your primary care doctor. But I sort of thought when we kind of talked to the library about what would be beneficial for the community, we thought something like cancer screening, something that's kind of applicable to just about everyone. Or if not to you, to someone that you know and you love. And I think it would be kind of interesting to get the perspective of somebody who's a medical oncologist, since not everybody ends up meeting a medical oncologist. So I work at Astera Cancer Care. We are located on Cranberry Road. We have an office in Monroe and breast surgeons that work at Monroe, as well as radiation doctors that work there. We have urologists as well. And we're also affiliated with Solera Primary Care. So we're kind of your neighborhood friendly doctors, and anytime you need, and we're more than happy to see folks and give presentations like this to sort of raise awareness. All right, so I like to just kind of go over what we're going to talk about. So first, we're going to talk about what cancers can be screened for and why we screen for certain cancers as opposed to other ones. We'll specifically talk about breast cancer screening, colon cancer screening, prostate cancer screening, and lung cancer screening. I did not include cervical cancer screening because I thought it would just take up too much time. So we're going to just do the first four that I mentioned, okay? So I like to start out with just general questions. And if you're in the chat, you can answer in the chat. You don't have to answer out loud. You can answer in your head, low risk situation here. So is this a myth or is this a fact? If I have cancer right now, I will absolutely feel it. Myth or fact? All right, so I'm hearing myth, which I would say is true. So most of the time, early stage cancers, you don't actually feel them. And so if you can't feel something, how do you bring it to anyone's attention? How does it bring itself to your attention? It doesn't. And one of the reasons I put this in here is that it's actually a common misconception. I definitely have patients that come to my practice, and when they get a diagnosis and they sort of say, how could this be possible? I felt fine. Well, unfortunately, that's sort of the reality of cancer, is when it's in its early stages, you do feel okay. And it's not until it's a little bit more advanced that you start to have symptoms from it. Okay, another myth or fact. If my blood work, quote, looks good, then I definitely do not have cancer. Myth or so Trudy is just not buying this game at all. So she says it's a myth. And so this one is definitely also a myth. And I included this as well because I have certainly had patients who come to my office and they sort of say, how could I have cancer? I had blood work done a month ago and nobody said anything was wrong. So if it looks good, I must not have cancer. But the reality is blood work doesn't usually tell us that there's something cancerous potentially going on, which is why we have these sort of screening programs. And then the last one, myth or fact. All cancer, regardless of the organ it originates from, behaves in the exact same way. Myth or fact? So I'm hearing a lot of myth again. Oh, okay. Where did I keep it? Oh, here. Thanks. So that one also is a myth. So cancers are all different. I mean, we call it all cancer: breast cancer, lung cancer, colon cancer. but they behave very differently from one another, you know? But in some respects, they do behave in some senses the same. And we're going to go into that because I think that's very important because we use this word cancer or tumor or malignancy or neoplasm, and it's sometimes hard to know what are we really talking about. So that's kind of brings me to my next point, like what really is cancer? You know, why is this so bad? So the way I explain it to patients is that it's an abnormal mass of tissue that forms when cells grow and divide more than they should, or they don't die when they're supposed to die. Okay, so uninhibited growth is kind of the simple way of thinking about it. Other terms that you sometimes hear are tumor, which can be benign, meaning it's not going to spread, or malignant, meaning it has the capacity to spread in the body. Malignancy, which means usually a cancer or a tumor that has the ability to spread. And neoplasm, which is the same thing as a tumor in that it can be either benign or it can be malignant, meaning that it can spread. So just to kind of give you an idea, you know, you have these cells in your body. So every organ in your body is just a network of specific cells. So this is the lung that's shown. It's not meant to be as daunting as it looks on here. But if you were to go deep into the lung and start using a microscope to see what actually is the lung, you'd see that it's just a network of cells. And these cells are very tightly regulated. They don't break rules, okay? And it's not supposed to do anything else. A tightly regulated cell is always going to follow the rules. And some of the rules that it will follow include performing the regular function. A lung cell is only going to do what a lung cell is supposed to do. It's supposed to work together with the other cells to deliver oxygen to your blood and take away carbon dioxide and allow your body to have fresh oxygen to all the organs. It's not going to start erratically and continuously dividing. So when cells grow, they grow by division. So a cell in the alveoli where gas exchange and oxygenation occurs, it's not going to start growing here, and all over and start blocking the alveoli. It's tightly regulated. A normal cell would never, ever do that. It's not going to start to invade into areas nearby. You will not find normal lung cells randomly hanging out in the liver. You're not going to wake up one morning, look at your hand and see a part of your kidneys. You know, that's not something that really happens because things are very, very tightly regulated. And it's the same thing that goes for all the organs. Lung cells are for lungs. They do what lungs do. Liver cells are programmed to do what liver cells do. And they're certainly not going to start to get into the bloodstream and start to go into other organs or into the lymph nodes and start traveling to other parts of the body where they can start to disrupt the function of other organs. So a cancer cell is the exact opposite of that. So it is considered malignant or bad because it has the ability to spread into or invade other areas and other organs of the body. So I always tell people, why would I care if you have just a random 2-centimeter lump in your breast if I knew it wasn't going to go anywhere or do anything to you? I wouldn't really care. It's the potential of what I know it will do by its natural history, which is to start to move to the bones, to the liver, God forbid, to the brain. That is why cancer is, bad, as we sort of call it. And so just as like a general treatment, and this becomes important because it helps to understand why screening for an early cancer is the best way to kind of prevent problems down the line. So if you find it early, generally speaking, and I'm talking about like solid tumors, I'm not talking about your leukemias and things like that. But if you find it early, the size is smaller, it hasn't spread locally, it hasn't gone to distant organs, you can generally cure a lot of these cancers with a combination of surgery, radiation, chemotherapy, and oral pills. So the earlier you find it, the better your outcome is. That is like without a doubt. So that's why screening is important because it offers you the advantage of finding something potentially early. And so why do we screen for it? So one, we want to find it at an early stage before symptoms would appear because we now know that you're not necessarily going to be symptomatic from a smaller cancer. And if you find it early, it's easier to treat and cure. It may be the difference of you get surgery alone or you get surgery plus you get a little chemo, okay? We can't screen for all cancers because some of them are too rare and some of them are just too aggressive to find early. And we'll go over that, cancer-specific sort of the natural behaviors as we go through. But I just wanted to show you the projection that the CDC has between 2015 and 2050 of new cases of cancer. And you start to see on this graph here that at the top, you have female breast, you have prostate, you have lung, and you have colon. So those really take the lead in terms of how common they are for the general population. And this entire talk is about the general population. I'm not talking about people who have clearly a family risk of it because multiple family members have had different cancers. I'm talking about, average person in the community. What are you statistically most likely to get if you were to, get a cancer? So breast cancer in women, prostate cancer in men, lung cancer and colon cancer overall. And you see that the other ones really kind of lag behind: melanoma, bladder cancer, kidney cancer, the rest of them. And so what you find is that, for example, it doesn't really make sense to screen for something like pancreatic cancer because it just doesn't happen that often to everyone, okay? And it tends to move quickly. So even if you were to say, get a CT scan or a CAT scan of somebody's pancreas once a year, you don't know if by the next year you really would have caught it that early because it could have moved pretty fast. Versus breast cancer and prostate cancer, colon cancer, it's a little bit slower. So you do kind of think that if you, have periodic screening, you can see it, and catch it pretty early. And there isn't really an option of doing CT scans every month or something like that. One, it would completely decimate and overwhelm the healthcare system if we're doing that for everybody. And two, it would just cause people to have a lot of toxicity from getting too much radiation. So it's a little bit of like a risks and benefits and what makes the most sense kind of scenario. And so that's really why, breast, prostate, lung, and colon are the cancers we screen for. And we don't screen for every single cancer by, getting a monthly full body MRI and CAT scan, which, maybe some of the celebrities are doing, but, for the average person who's doing it the way that's recommended, we don't really do that. And so what cancers can we screen for? So breast cancer, I'm including pictures because sometimes we say things like colon cancer, but we don't really know what the colon is. And so colon is just the large intestine. And then prostate cancer, which we sort of know, close to the bladder. Lung cancer is self-explanatory. And then cervical cancer, which again, I'm not talking about it in detail, but it is a cancer that you can screen for. And so general notes about cancer screening, if you were to look it up, there are many organizations that are going to make recommendations for the details regarding cancer screening. So what age should you start? How frequently should you get this cancer screening? And some of the organizations that you may see are the American Cancer Society, the American College of Physicians, ACP, the American College of Radiology, ACR, the National Comprehensive Cancer Network, which is the NCCN. And then there's the U.S. Preventative Services Task Force. So that's the USPSTF. And that is what I think a lot of primary care doctors sort of use their guidelines to kind of say exactly how they would do the screening. Though what's nice is that when there are multiple recommendations, it actually allows a little bit of flexibility because maybe for one patient, you're sort of thinking, oh, well, I don't know, maybe doing it a little earlier in this because of XYZ history makes more sense. It allows some flexibility, but I would say by and large, if you wanted to see a specific organization, I think the USPSTF would be absolutely appropriate for majority of average risk people. And then I sort of already indicated this. There are special circumstances for certain patients in which you might do an enhanced screening or you start screening a little earlier because of some personal or family history. That's a very nuanced conversation. That's why it's very important to have a primary care doctor who kind of knows you, who knows your family history, and sort of knows and can be sort of dedicated to figuring out what is the right screening for you. And so, as I mentioned already, we're going to talk today about average risk people and not necessarily people who are at higher risk. And so for breast cancer screening, I'm just showing a picture here of the steps of breast cancer development. So usually, it starts as some sort of dysplasia, meaning the cells are starting to look like they're becoming abnormal. Then those abnormal cells start to form and divide, and you start to have detectable masses. Then that mass divides more, becomes bigger, and starts to spread out, potentially going into the lymph nodes, going into blood vessels, and then it starts to kind of locally invade. So that's kind of the natural history of what would happen with breast cancer. So if you find it here with a screening mammogram, it's far easier to do a surgery than if you find it when it's a little bit bigger and starting to invade. And breast cancer is very common. Average risk females have a lifetime risk of 12% of being diagnosed with breast cancer. Now, that doesn't mean that 12% of women are going to die from breast cancer, but it does mean that it is something that's highly prevalent in the population. And the way we screen for breast cancer is with mammography. And many women who have gone through it kind of see the familiar sort of figure of getting the breast sort of squeezed between this mammogram machine that uses low dose X-rays to look at the breast. And usually they get this sort of image that comes up of the breast with the natural sort of contours in gray, and then this very bright spot that looks kind of more suspicious for cancer. And so the technician performs the test, and then usually there's a radiologist who reads the actual scan to kind of look through and see, does anything look suspicious? So the benefits of screening mammograms are very high. So it reduces the odds of dying from breast cancer by approximately 20% overall, and that's probably a lower estimate. And the benefit happens to correspond to the age group that you're in, because as you get older, breast cancer becomes more common. So as an example, if you're between the ages of 60 to 69, you actually have about a 30% risk reduction. And so through medical advances and screening, we've actually done a better job of curing people with breast cancer, and the number of people that have died has decreased by 44% since 1989. And we attribute about a third of that to just better breast cancer screening. The risks of it, I think there's a lot of anxiety because you're not sure what they're going to find. There can be false positives, there can be false negatives, and of course there can be discomfort. So sometimes people will use topical lidocaine during the mammogram or Tylenol and things like that to kind of help with it. But it's not necessarily a totally comfortable experience either. And so I just kind of listed out the groups here and their recommendations. So from our trusty USPSTF, they would recommend starting from at the age of 40 to 74. And the frequency they recommend is 2 years. It's not wrong to do it annually. It's just that the benefit between doing it annually versus every 2 years seems to be low. But I would say a lot of primary care doctors do order it yearly, and there's nothing wrong with that because the other societies are recommending annual mammograms. And you'll sort of see that some of the other societies will have different recommendations for different age groups, because as I told you, the risk becomes worse as you get older. So if you're 40 to 44 and you looked on the American Cancer Society, it would actually tell you to individualize whether or not you would screen those patients. But if you're 40, once you hit 45, it's recommended that you should be getting mammograms. I want to talk a little bit about older age and getting mammograms. It's not that you have to have a hard stop at 74. I think that is definitely something you can individualize. I definitely have patients in their 70s who I think are going to live another 20 years because they're so in such good health and they're doing so well. So for that person, I still think a mammogram would actually be reasonable. Like they're not, they're not in a decline in any sort of way. But it is an individualized decision. Again, another really good reason to have like a good primary care doctor who really knows you and can look at you like holistically. So then we'll move on to colon cancer screening. So colon cancer, it usually starts out with another proliferation of abnormal cells, and those cells turn into what we call adenomatous polyps. So an adenoma on its own cannot move to another location, okay? So it doesn't do what a true cancer does. So it's not considered cancer. It's actually still considered benign. However, it does have the ability to turn from an adenoma into an adenocarcinoma, which is a cancer. And so it kind of exists on the spectrum and this range. And the natural history is that these polyps, when they become adenomas, will turn into cancer in about 10 years. 10 years is a long time. It actually is good because it's quite slow. So you really can catch this early before it turns into something a lot more sinister. And the lifetime risk of developing colon cancer is about 4% for the average person. And so, you know, it's something that's pretty significant. And because it's so slow, it's much easier to catch. So it's higher yield for us to do screening. But colon cancer screening ends up being very confusing in 2025. What used to be just get a colonoscopy and call it a day, we have actually a lot more options now. And so one thing I want to show you is just how the incidence of colon cancer will increase with age. So you sort of see that starting around 45 here, it really starts to take off how often or how many new cases that you sort of see in that age range. And so there's a reason why we don't, you know, screen people who are necessarily in their 20s and 30s, because it's not very common for those patients to get colon cancer. But once you sort of hit 40, 45, we really start to think about it, especially 50. So for the average risk individual, we would do screening at the ages of 45 to 75. And the same sort of caveat with the colon cancer screening at 75, just because you're 75 or 76, you know, I think you do have to have somebody look at you sort of holistically. Since there are a lot of options, you don't necessarily need a colonoscopy, but you may benefit from some sort of colon cancer screening. So the types of screening. So colonoscopy, which I think everybody knows, the dreaded colonoscopy. This one is the highest sensitivity for both colon cancer and polyps. It's a procedural-based study. It's done every 10 years if everything looks absolutely pristine when they go in for the colonoscopy. There are risks to this one, you know, anxiety, of course, bleeding, potential perforation. It's not common to have a serious harm, about 2.8 in 1,000 patients. And then if you're someone that has heart disease or lung disease, because you'd be getting some anesthesia, there's a risk for patients that have severe heart and lung related medical problems. And so this is kind of the picture of the colonoscopy. So what it involves is that you'd have to take a prep solution that will literally clear your bowels, and for good reason. So what you're going to do is the night before, you would drink a solution that would eliminate any fecal matter from your bowels, so that when the GI doctor goes in to look at your colon, what they see is absolutely clear. You know, they're not like confused about what is there, what is being seen. And so, you know, you would be asleep, you'd be on your side, they would insert the scope into the rectum and look inside all the way throughout the entire colon and see, are there any of these polyps? And if they see a polyp, they're able to usually remove it, which is good, because if you had an adenoma polyp, which you wouldn't know until you snipped it out and looked at it under a microscope, you could have saved yourself from having a developing colon cancer within, you know, the next 10 years. And so that's why this one has a very high standard to colonoscopy, because there's sort of a therapeutic benefit to it as well. But there are other tests, because colonoscopy may not be the right test for everybody. And so now we have all these stool-based testing. And so you may have heard of the FIT or the FOBT test, which checks for hidden blood in the stool. And that's done yearly. The idea being that colon cancers and adenomas sometimes will cause microscopic amounts of blood that you may not see with your eye. And there is also now Cologuard, which I'm sure everybody has heard about, which is a multi-target stool DNA test. So it looks for blood and DNA mutations of the stool, which can indicate that there is a malignant or cancerous process going on. And that can be done once every 1 to 3 years. And it requires that you actually send physically the stool sample to the company. The caveat for this is that if any of these are positive, if this is a screening that you choose and it's positive, you sort of buy yourself a colonoscopy, because it's very, very sensitive in terms of picking up colon cancer or adenomas. And then the last type of screening is called CT colonography, which is just a CT scan in which they give you an ingested material that allows them to look and see are there any polyps or any colon cancers that are there. That's usually done every 5 years. And you'd have to get a colon go through a CT scanner machine to do that. This is a graph that kind of just tells you how good each test is. So I just want to focus here first on the colonoscopy. So the purple is telling you the sensitivity. So how good is it at picking up in the purple colon cancer? 95%, which is very, very high. So this is clearly the best test in picking up colon cancer. And then it tells you in the green, blue, and orange, how good is it at getting adenomas of various size. So green is greater than a centimeter. Blue is between 6 to 9 millimeters, and then the orange or the yellow is less than 5 millimeters. So you sort of see that it's obviously when you're directly visualizing it, you're able to kind of pick up these adenomas pretty well. If you compare that to those stool-based tests, so the FIT test or the FIT DNA or Cologuard test, you see that the FIT and the Cologuard test are still pretty good at picking up colon cancer, but their ability to pick up these adenomas is so much less, right? So you kind of see how the green, the blue, and the orange really drop off. CT colonography does pretty well in terms of picking up colon cancer and larger adenomas. But again, you sort of see a similar sort of drop off when the adenomas start to become a little bit smaller. So which test is best is the question. And so the answer really is that it can vary. Depends on your age. It depends on your medical problems. And the golden rule is that any form of screening is better than just not doing screening. So you want to do something because they are all pretty effective, but you don't want to sort of say, I'm so worried about doing the colonoscopy that I'm just not going to do any screening. Maybe, the FIT testing or the Cologuard is something that's more correct for you. Or maybe you're a little bit older, you have heart and lung problems, going through anesthesia is a high risk for you. So doing the CT colonography maybe makes more sense for you. So colonoscopy tends to be the highly recommended tier of tests, according to the U.S. Multi-Society Task Force on Colon Cancer. So just sort of keep that in mind. But again, any form of screening is better than no screening, and it's good to know for the general population that you really do have a lot of options as to what you can do. Then I'm going to go a little bit into prostate cancer screening. So prostate cancer is very, very common. It accounts for about 29% of cancer diagnoses in men in the US. The natural history of prostate cancer is that it usually grows very, very slowly. Not every time, but majority of prostate cancer or much of prostate cancer is very, very slow. And what that means is that most men are going to die of other causes before the disease becomes clinically advanced. And in fact, they actually have done a study where they did an autopsy of males who died of other causes. And so, they died of whatever, heart disease, lung disease, whatever they may have died of. And when they did the autopsy, they were able to detect prostate cancer in about 30% of the males that were in their 50s and 70% of the males that are in their 70s. So what that means is you're far more likely to die with prostate cancer than you are to die from prostate cancer, because it's a little bit, tends to be more of the sleepy variety when it comes to cancers. The research on doing prostate cancer screening is not clear. It's very, contradictory. And so by and large, from the USPSTF, it probably has a small benefit to do screening in terms of reducing prostate cancer mortality. So what we sort of tell people is that, it's a shared decision that you do with your doctor. And the way we screen for it is a blood test. So it's pretty easy. It's not that big of a deal to get a blood test called a prostate-specific antigen. And this is a protein that's made by the prostate gland. And when it's very, very high, it can indicate that there's prostate cancer going on. And so just because that's the screening, that doesn't mean that you have diagnosed anything. So really to diagnose the prostate cancer, you would need a biopsy. And that's sort of where the risks really are more likely to come in. Things like infection, pain, bleeding, urinary obstruction can happen when you get a biopsy of the prostate. And the problem is that the PSA is just not a perfect test. So it can be elevated for reasons that are completely unrelated to cancer. So recent infection, inflammation. If your prostate is just larger because you're an older man, which is very, very common, the PSA can be elevated. Certain medications can elevate the PSA, prostate stimulation, even vigorous exercise can elevate it. And so who gets screened then for prostate cancer? And that ends up being very much a shared decision between you and your primary care doctor or your urologist as to who gets screened. The American Cancer Society would sort of would say that if you're between the age of 50 to 75, that's really the time period in which you would probably see that benefit. So those are the ages to screen. 45 if you're higher risk, meaning that you have a father or brother with prostate cancer if you're African American, and 40 if you're at the highest risk, meaning that you have at least one or two, or you have more than one family member with prostate cancer. And so it's important to know that, the majority of men who choose not to be screened with PSA tests will probably not get diagnosed with prostate cancer and will probably, not die from it either, as we sort of know. There probably are some people who would have benefited from screening if they chose not to do it, because they were, they may, get prostate cancer and have a more advanced stage. So, it's a little bit of a mixed bag. I think that it kind of also depends on the type of person you are. So some people are far more, I want to know everything going on with my body. I'm okay with any of the risks, related to biopsies and things like that. And for that person, I sort of say, go for it. You're kind of like the perfect candidate for this kind of thing. And then there's some people that are a little bit more like, I would just much rather not have this done. If the risk for me is low and the benefit for me is potentially low, and it's going to just cause me a lot of anxiety and grief, I would just not rather have this. And, I think both things are appropriate. I think we have to look at people as who they are and kind of have sort of a holistic sort of recommendations for each of the patients that walk into our clinic. So that's like the most unsatisfying one is prostate cancer, clearly. Lung cancer is the last one we're going to talk about. So lung cancer screening is the one that is actually not necessarily applicable to the general population, but I add it because it is something that we're just not quite good at getting. And so I'm sure everyone in the audience knows that 85 to 90% of all lung cancers are attributed to cigarette smoking. And about 1.6 million deaths occur due to lung cancer alone annually, which is a very high number. Survival really depends on the stage for lung cancer. So the size of the tumor, if any lymph nodes are involved, if it has moved anywhere. And so I'm just going to show you kind of a graph of the overall survival by stage. This is all looks like nonsense, but basically the blue is smaller tumor, less lymph nodes. And as you go down, the tumor is larger and there are more lymph nodes. And you sort of see that at the 2-year mark, if you were to have somebody that had a smaller tumor, you would actually still expect that they're going to be alive. And even, many years later, they're probably still going to be alive because it's a smaller tumor. Versus a larger tumor with lymph nodes that are involved, which you may not have symptoms, until it gets larger. When you hit the 2-year mark, it's far less likely that, you would potentially still be alive. So it really, really matters to catch this early. You really can, help somebody to survive, or help their probability at least of survival. So the benefit of screening is to cure more people and to allow also more limited surgeries if surgery is what we're going to do for cure. So there's an estimated 20% reduction in death if you do the screening. And how do we screen? We do it by an annual low-dose CT scan in patients that are high risks. And so this is just a picture of somebody, going into the CT scan machine. It's that little donut, and you kind of go in. And this is a picture of what those scans kind of look like. So again, you would be looking at the lungs, and the radiologist would sort of look through and read and see, does anything here look suspicious? And so who qualifies for lung cancer screening? So according to our USPSTF, you would do a yearly low-dose CT scan if from the ages of 50 to 80 if you're high risk. And who's high risk? Someone that smoked approximately 1 pack of cigarettes for 20 years, which is 20 pack year history, or half a pack of cigarettes for about 40 years, which would still be about a 20 pack history. And they're either a current smoker or they quit within the past 15 years. So it's a really kind of a narrow number of people that would qualify for this, but it's so important if you know anybody or if you have a family member, if this applies to you, for you to know to know about this, because we're, again, as I told you, we're pretty bad about getting this. We're only getting about 15% of eligible candidates in to get those annual low dose CT scans. And so, you know, you can imagine how many patients I have who, you know, they were not getting these low dose CT scans. They come to me with more advanced lung cancer. And I tell you now, so many of them say, I wish I knew about this. And so that's why, you know, I think it's important for us to talk about this, even though it doesn't apply to the general population. I think it's good if we kind of just made this go viral or something so people could know about it a little bit more. And then finally, I have to sort of add that quitting tobacco use is by far the strongest recommendation any physician can make to reduce the risk of cancer. So tobacco use actually is not just associated with lung cancer, it's associated with about 12 different types of cancer, which is not as well known in the general population. So, you know, cancer of the head and neck, cancer of the bladder, even leukemia, cancer of the stomach, esophagus, all sorts of things. So quitting tobacco is the number one thing a person could do for their health if somebody is an active smoker. And so in summary, I've kind of just added here, you know, the breast cancer screening recommendations for annual mammograms at ages 40 to 74 or more, or every 2 years, and colon cancer screening from ages 45 to 75 or more with the various testing like colonoscopy, the stool-based testing, or the CT colonography, and then prostate cancer screening with just PSA blood work, which is a shared decision that you make with your doctor. And then finally, lung cancer screening from the ages of 50 to 80 for people who are high risk, tobacco use or prior use, with a low dose CT scan of the chest annually. So that's all I actually have today. Thank you for listening, and I am happy to take any questions.